President, Council, my dear colleagues, and all members of the UVA Clinical Society. It's great pleasure for me to address you today in your annual academic sessions. First of all, I would like to thank the President and the Council for the kind invitation extended, and especially Asela and Carl for making the arrangement for make it possible for me to address you. The topic given for me today is the clinical assessment of back pain. Back pain has made a remarkable increase in presence in our society over last many years. In 2015, it is the fourth in cause of disability when it adjusted for life years in all nations. It's well known 65 to 80% of the world population is affected at least once in their lifetime, and of course the recurrences are common. When it comes to causes, the mechanical are the commonest, which I'm going to address you to more on that more today, especially when it comes to management. It happens with overuse of normal anatomical structure or due to a trauma, degeneration, or deformity of an anatomical structure in the spine. Very difficult to get exact pain in when it's a mechanical back pain. It can be bone, cartilage, joints, muscles, ligaments, or tendons around the spine. There are medical causes of back pain which are important first to look into, because that you need to treat them properly at the onset itself. So there are many illnesses which cause that, and it can be related to any of the systems in our body. When it comes to mechanical back pain, what's the good news is most gets better, whatever treatment modality we use, but it can take some time to get better, and during that time, it will affect the person's life activities, including the earning capacity, and that makes a loss to the country's economy as well. Generally, over 50% of the patient will improve after 1 week, and over 90% better by 8 weeks, and only about 10% will continue for more than 6 months. Even though it's shorter, that problem during that short period is an issue for the patient and maybe even the economy of the country. The recurrences are also common. That's the main reason that we are most of the time worried about. And if we treat them early, the recurrence seems to be less. So if we treat them early, you get them back to their work and their activities, and their mental status will be better, as well as your recurrence rate will be better. And to make a treatment early, you need to make a proper diagnosis and then make the proper form of treatments without overdoing things or making it more expensive for the patient to go through a lot of other investigations and treatment. It required an arranged and thoughtful approach tailored for the specific complaint. So what we are looking in a back pain patient is, first of all, to differentiate whether it's mechanical or medical, and also what are there any features which we call sinister features which need early intervention, and I'll come to them later. So as usual, medical field, what you have to do is through getting a proper history and a very well-directed examination to come to your conclusion or make your diagnosis, or at least a differential diagnosis, before proceeding to any of the investigations that are generally done for a back pain. Age can make a difference. Young and old have different causes. Male and female also can have more common different causes. The onset and duration is important to go in the history, get it in properly in the history. The mechanical ones, then the onset is generally with a physical task and generally present within a short duration of onset. The medical ones are generally gradual onset, and they have a longer history of getting it worse slowly, and generally there's no precipitating factor to start that or have started that back pain. The location of pain. Ask the patient to indicate where exactly the pain by finger pointing to the best way rather than just diffuse. Generally, they will tend to give it sort of a broad features or broad areas when they talk. So most mechanical ones are limited to lumbar sacral region. If it's radiate to the thigh or knee, it's generally coming from the elements of the spine, the muscle, ligament, epiphyseal joint. If it's radiate below knee, it's either neurogenic or radicular, where the nerve radicals are involved. If it's mechanical, generally it's worse with activities, including prolonged sitting and standing. It improves when you lie down and recurs in basis with same degree of activity. Same problem or same activity, but you do will give back the pain. The medicals, whether if it's infection or inflammation, most not related to body position, with compression may find relief with complete immobility or lying down. If it's inflammatory, you usually get the inflammatory feature, that is early morning stiffness, that is stiffness after prolonged rest, worse in the morning, and get better, worse with rest as well, and get better with activity and towards the evening. The tumors in the lumbar spine is worse actually with lying down, and especially middle of the night pain is something to worry about in back pain, which could be a neoplastic issue. And if there are constitutional features, that you definitely have to look for a medical cause, either inflammatory or infection being the major reason, or could be neoplastic. Features of increased CSF pressure indicates you that patient is maybe having a severe compressive lesion which need early intervention. It could be prolapsed disc, abscess, or neoplasm. So they generally have radicular pain. Pain increase with coughing and sneezing. Sudden motion cause pain due to spasm of paraspinal muscles, and there can be bladder and bowel incontinence due to the cauda equina compressions. The family history, occupational history are important, as well as the past medical history, especially of past neoplasms or TB and other infections. Should have a systemic review, including skin in history, to see whether anything medical related ones are happening in the other systems, which may be the reason for the back pain. Once you sort out it into looking into the medical and mechanical problems with also some features of sinister features in the history, you move on to your examination. The mechanical pains in the history, you are generally can evaluate of musculoskeletal and neural tissues of lumbar spine and lower limb, and may start treatment. And if there's no improvement with treatment, you may need to do a proper, maybe a better or more detailed examination. Can do that in a OPD setup. If you think it's more mechanical in the history, you can run through the more limited examination and start treatment. If there's features of a medical issue, you have to start with general examination and do a full examination of the spine as well as all the systems. When you examine the spine and related areas, you have to do it in an orderly fashion, minimize the time and discomfort of the patient, because remember, they are with the pain most of the time. So what you can do is start with standing examination, where the posture is the most important part you have to examine, whether there are kyphosis, scoliosis, and then you do your flexion, anterior flexion. You can do your Schober's test at this time itself, so to see whether there is any reduction of lumbar flexion. And then you do the extension to see whether there's any increase in pain. And lateral flexion is important, especially when in inflammatory spondyloarthropathies. The lateral flexion of the lumbar spine and the neck are the first restriction movement which occurs even before the Schober's become positive. You do your rotation, and then you do your walk test to see the gait, which might give you a clue where the problems are. And also remember to look at the whole body from the limbs upward to see whether there's any malalignments. What we mean by malalignments is there's changes in the kinetic chain with changes in the foot, ankle, knee joint, hip joint, pelvis, and even in the scapular region, which lead to abnormal postures, which are also found to be one main cause of mechanical back pain in our patients. Those unless you address these malalignments, your patient's back pain will keep on recurring. The physical examination then moves from the standing. You do look, if you want to really to see whether the curvatures and postures deformities, the normal position will be D1 centered on sacrum and posterior iliac superior spine equal heights. Gluteal folds, knee joint should be at the same level. And then you can do the walking with the toes and heels to see the neurological defects in the lower lumbar and sacral radiculopathies. And as I told you, look at the other movements of the spine. And this is the Schober's test. You know how to do that. And important in spinal, the spine in the spondyloarthropathy examination. And notice the bending spine on your left side, which is actually bent in a straight line. In normal person, they will have reversal of the lumbar lordosis and there'll be a curvature happening when you bend fully. And when you have stiffness due to inflammatory arthropathies or sometimes even due to severe back pain, the movement where the spine will be in a straight line even after bending, because their movement is from the hip joint, not from the spine. When you have pain in flexion, generally that you give a clue that it gives a clue that the problem is in anterior element of the spine and the disc. If it's in extension, it will be in posterior elements, including the epiphyseal joints. Pain with lateral bending to the same side is generally epiphyseal joints. Opposite side pain is muscle, ligament, or fascia. Which these are a few clues that you might get when you examine, which might be helpful in your further treatment of this patient. Once you finish your standing position, you put them on supine, lying down. And one of the most important tests to do on lying down is to do the straight leg raising test. If there's irritation of L4, L5, S1 dura, root or sciatic nerve, you will get a positive test. That is, you have pain which starts from the back, run behind your thigh, below the knee, that is below the knee, in the back of the leg, and it may run up to the toes. And generally this happens at the range of 30 to 70 degree of extension of the whole leg. If pain comes after 70 degrees, that may be root irritation, but most likely to be mechanical due to muscle strain or joint pressure. And radicular pain increases with dorsiflexion, and generally radicular pain, which comes in 30 to 70 degrees, generally increase with when you dorsiflect the foot at the pain site when the pain comes. Pain of the affected side with the contralateral leg raising is due to the large central disc prolapse. There's something called bilateral straight leg raise test also. Again, 0 to 70, pain may be due to sacral joint stresses. And if that pain comes over 70 degrees, that is lumbar spine problems. And pain in lower level than unilateral test is a psychogenic low back pain, as well as if there's pain in the unilateral straight leg raise, or pain before 30 degrees is generally, again, you have to consider possible psychogenic low back pain. The physical examination of the supine. The next is the leg examination for neurologically. Look for which pain area, what's the numbness area, and what are the muscle weaknesses for evaluating L4, L5, S1 especially, and might apply to L2, L3 as well. And you have to look on supine, look for the limb length. As I told you, malalignments and other issues can have the same problems. Examine the hip joints. Sometimes back pain, what the patient refers to as back pain, actually coming from the hip joints. And also examine the sacroiliac joint. There are different ways to do that. And next, there is you put the patient, ask the patient to go prone. And the important test there is what called femoral stretch test, which tests the upper roots, that is L2 to L2, L3 mainly, and maybe a bit of L4. And where you bend the knee, flex the knee and to 90 degrees and elevate the thigh from the bed. If the pain is in the anterior or medial aspect of the thigh, that's taken as a positive test for these nerve root irritation. Then check for the sacral sensation, looking for cauda-equina issues, and look for tender sites on the spine and also the sacroiliac joints. Of course, when you have back pain, there can be very diffuse tenderness which does not indicate any, you can't differentiate anything from that. So just see whether it's a diffuse tenderness or one localized position. So going through that, all these are important in your management. When it comes to management, how do you decide the management of this back pain, especially if it's mechanical? So if you need further investigation referrals, if you have cauda-equina compression, that is evident by bilateral sciatica with neurological signs, if you have saddles anesthesia, and if your patient has a bladder or bowel incontinence. These patients need immediate neurological referral where they can do the quick MRI and decide on possible surgery. So you don't need to wait for any MRI and things in these patients. It's need to be quickly referred, because if you spend time looking for investigations, that patient might end up with a more worse situation and non-recoverable nerve weakness, ending up with a long-term disability. If there are features of medical cause like fever, weight loss, increased pain on lying down, early morning stiffness more than 1 hour, acute localized lumbar sacral bone pain, visceral pain with GI, GU disturbances, maybe early morning, the pain worse in the morning and worse with rest. Those are the things that you have to think about medical causes. But elderly also, you may need to do a basic investigations, maybe about 50 years patients. It's routinely do a ESR and plain radiograph, because the malignancy can present as a back pain in these patients. Below 50 years, generally we don't need, if the history and examination suggests it's a mechanical, you don't need any of this investigation. You can straight away move on to your management. So how we do the management, you have on those patients who have 4 to 6 weeks of conservative therapy. Those are the ones who don't have any sinister features or what have we described earlier. And these patients who are with a mechanical back pain, without sinister features, you start with patient education of how to do the activities, what their postures should be, what should be done and what shouldn't be done. If you are doing things, how to do that. Those are the important things there to educate the patient. You can use analgesia like paracetamol, and even stronger one like tramadol if it has severe pain for a short period. NSAIDs will be helpful. More importantly, the muscle relaxant, because most of the pain is generally due to secondary muscle spasm initiated by whatever the radicular or joint or bony problem causing the pain. So once the muscle going to spasm, that keeps on having pain. So that muscle relaxant like diazepam, tisonadine, or baclofen can be used. And of course, you need to start your physical therapy. The pain can be reduced by heat therapy, and then there are other things like to prevent you from the pain or to come back. You need to do your strengthening exercises, as well as the spasms can be reduced by stretching exercises. Always try to downplay the illness behavior of patients, because otherwise you are going to end up encourage and you end up with a patient who are going to have chronic pain and trying to gain some economical or social benefit out of that. So always encourage them to resume normal activities as soon as possible. Prolonged bed rest should not be encouraged or advised on these patients. If you have very severe pain only or sinister features, that you keep them in bed. If it's sinister feature, of course I told you that you need to get it investigated by the neurosurgeons. If it's not, you keep them in a until the severe pain lasts maybe a day or two. You may keep them on bed rest, but if it's only severe pain, others try to mobilize them as much as possible. If the failed treatment which I mentioned above, or the treatment which I mentioned above fails after 4 to 6 weeks, patient still having the pain, then we investigate or manage them further, breaking them into 4 groups. Whether their pain is localized, or whether there's pain below running radiating below knee, the sciatic pain, or is it only an anterior thigh pain or only a posterior thigh pain. And on this we can manage them. If it's localized, which is the largest group, you do your plain x-ray now to see whether there's evidence of spondylosis or spondylisis or spondylolisthesis. Most of these things again will need further more advanced physiotherapy, and still not responders, then you need to reevaluate for a medical cause as well, and maybe further investigation of MRI may be an indication. These are few x-rays showing spondylosis, spondylolisthesis, and spondylolysis with the spotty dog with the collar absence, with a collar. If the leg pain runs below knee, that is a radicular or sciatic pain, they are of course not responding to treat medical general therapy and other medical treatment for 6 weeks. Will need a MRI or CT myelogram to see how much of a disc bulge or any other compression lesion is there. And depending on the severity, you might decide on surgery with the opinion of a neurosurgeon's opinion. If they think it's still not needed, you can still continue with the physiotherapy. And of course, the epidural steroid injections also reported to be effective in these patients. Of course, in this patient, if there are any neurological lesion to be seen, then surgery should be indicated. The anterior thigh pain can come not really from the back, but which is not respond to the back management. It could be from hip disease, inguinal hernia, kidney disease, and ureteric stones, femoral neuropathy to maybe diabetes mellitus, and or retroperitoneal problems in aorta and kidney. So we need to further investigate into looking into these features. The posterior thigh pain refers from the lumbar spinal structures and could be radicular pain from L2, L3, which need again continued treatment and maybe MRI and other investigations to see whether there's any compression. So if you look at the overall picture of a mechanical back pain treatment, you may need pharmacology. We'll need physical therapy to increase the flexibility as to reduce spasms, and strengthen to improve and maintain. As I told you earlier, biomechanics corrections may be needed who are not responders, and also if you detect biomechanical problem, early examination, especially in the standing, that you have to look for these problems in the foot, ankle, knee, hip, and even neck. And long term, you need to have good patient education, continue with self-examination, exercises, continue to prevent any recurrences, may need to have some behavioral changes like not pick things up not by bending the spine, but by bending the knees and going down, taking up, and using orthotics. And always encourage them to continue their work, but may need, as I told you, some behavioral changes or way he does his activities need to be advised. So those are the important things, and not to stop them working and or making them to have a prolonged bed rest and things. And I don't think there's any indication to have hard surface to sleep on these patients. That probably will make things worse. So don't ask them to sleep on planks and things by removing the things, or sleep on the floor. Of course, we have a lot of functional low back pain patients, especially younger male and females, needing medicals, trying to get out of other stressful situations in home, work, and other things. So how to detect them? There will be a lot of tenderness even to superficial touch, inconsistent results in confirmatory testing like SLRT and bending test, abnormalities not following the neuroanatomical structures, and there's overreaction to everything we do. So important to sort them out before trying to investigate and doing unnecessarily investigating them, and they need a lot of counseling and finding out the history, what real reason behind the continued presence of back pain. So in summary, ladies and gentlemen, low back pain is a common problem. Over 90% are mechanical. Need to treat early to prevent chronicity and recurrences, and to loss to the income generation and their psychological status. Clinical evaluation through history and examination, looking for whether it's mechanical or medical is important, and always look for the early stage, the sinister features or red flags. And further investigation done early if you find cardiac venous syndrome, medical causes, and also in the elderly people. Others you treat 4 to 6 weeks with analgesia, physical therapy, activity modification, and also with muscle relaxation. Important to downplay illness behavior, and prolonged rest should not be recommended. And non-response to these are investigated further according to distribution of the pain, as I told you before. Thank you very much for inviting me and sharing my thoughts on back pain with you all. I will be happy to answer any questions if there are